Are your Oasis assessments truly accurate, or could small errors be costing your agency thousands and even impacting patient care? In part 1 of our Oasis review series, we'll show you the most common mistakes, how to spot them, and best practices for QA that keep your documentation compliant, accurate, and audit-ready. Whether you're a field nurse, therapist, or an agency QA reviewer, accuracy in Oasis is absolutely critical. Why? Because Oasis impacts Medicare payment under PDGM, patient outcomes, care planning, and even your agency's quality ratings under the Homehealth Quality Reporting Program, Care, Compare, and Star ratings. This video is intended to help you review Oasis efficiently, reduce errors, and strengthen compliance, ultimately improving both patient care and agency performance. All Oasis data should be audited for 1. Accuracy of clinical data. Functional scores reflect true patient status. Assessments match nursing narratives. Diagnoses align with physician documentation and the plan of care. 2. Consistency. No contradictions between Oasis items. 3. Completeness. 4. Compliance with CMS regulations. Completion within required timeframes. Accurate coding that supports medical necessity. 5. Survey readiness and quality measures. Vaccination status, fall risk, depression screening, and pain assessments are documented and consistent. Functional outcomes align with goals, education, and emergency preparedness documented. 6. Patient-centered care alignment. Goals match functional limitations and patient voice. Interventions address identified risks. Narrative supports medical necessity. And 7. Reimbursement alignment. Primary diagnosis supports reason for skilled care. Comorbidity adjustments captured. Functional scores are realistic and justified. Ensure correct entry of name, dates, and time in and time out. Appropriate primary and secondary ICD-10 codes. Orders for discipline and treatment goals appropriate for diagnosis. Specific goals identified that are measurable, patient-centered, and time-bound. Physical therapy, occupational therapy, speech therapy, MSW, home health aid are included with appropriate frequencies when indicated. Oasis completed according to guidelines within 5 calendar days of start of care, 2 calendar days for resumption of care, within last 5 days for Recert, within 2 calendar days of knowledge of event for transfers and discharges. Consistency and alignment in functional status assessment items, proper entry of medications in medication profile, compliance with standards of Medicare reimbursement, compliance with state regulations. Unlike PDGM, which is about reimbursement, survey outcomes are tied to quality measures, compliance, and patient safety. When surveyors review charts, they look for consistency, accuracy, and patient-centeredness in Oasis. These areas deserve extra QA attention because they directly affect survey deficiencies, quality outcomes, and star ratings. The following are the Oasis areas that impact survey outcomes: patient identification, hospitalization and emergent care risk, vaccination status, depression screening, pain assessment, fall risk, pressure ulcers and skin integrity care, medication review and management, emergent care and avoidable events, functional status accuracy, patient preferences and care goals, patient education and emergency preparedness. Next, we will tackle Oasis areas that affect PDGM payment. 1. Clinical grouping. This is tied to the admitting/primary diagnosis used to assign the PDGM clinical grouping. QA must ensure Oasis narratives, coding, and physician face-to-face documentation all align with the chosen primary diagnosis. 2. Functional status. QA must cross-check these keenly as these scoring can swing payment significantly. 3. Comorbidity adjustment. This is based off of secondary diagnoses. Comorbid conditions must be supported by physician documentation. Correct capture of comorbidities can increase reimbursement from no adjustment to low or high. 4. Timing of episode. Oasis must support whether this is an early or late 30-day period. QA should confirm that dates and sequencing are correct on start of care and resumption of care. 5. Admission source. Community versus institutional. Institutional admissions generally reimburse higher. In this next section, we'll focus on one of the most common areas where inconsistencies show up frequently while performing Oasis QA, the functional status. The goal is to make sure what's documented in the functional assessment sections of the Oasis are consistent, in alignment, and actually matches the patient's real clinical picture and documentation throughout the Oasis. This protects your agency from denials, ensures compliance, and most importantly, supports accurate care planning for the patient. Let's walk through a few real-life examples where Oasis scores may not align with clinical findings. Each of these examples shows how important it is to cross-check answers, ensure consistency, and link the documentation to the actual patient picture. If MU 1830 bathing equals 0, indicating independence, and narrative or orders mention grab bars, shower chair, or caregiver assist, then reassess independence. If MU 1850 transfer equals 0, indicating independence, and transfer board, gait belt, or one-person assist is documented, then consider MU 1850 greater or equal to 2. If MU 1860 ambulation equals 0, and walker, cane, or wheelchair present and documented as being used, or physical therapy ordered for gait training, then reassess and update. If patient has an oxygen concentrator documented and equipment is in the home, and O2 sat 90% with minimal exertion, and MU 1400 equals 0, no shortness of breath, then consider reassessing MU 1400. If shortness of breath documented with minimal exertion, e.g. walking room to room, then clarify MU 1400 and suggest a score of 2 or 3 depending on effort thresholds. Always cross-check functional status assessment, MU items, with corresponding prior functioning abilities, GG items, for consistency and alignment. This is one of the fastest ways to catch inconsistencies that can hurt accuracy, care planning, and PDGM. Section GG indicates the patient's usual ability with everyday activities prior to the current illness, exacerbation, or injury that initiated the episode of care. MU items identifies the patient's current ability to safely perform the task. Preferred method of assessing MU items is assessment and observation. The assessing clinician may also interview the patient and/or caregiver, conduct environmental assessment, and input from other agency staff with direct patient contact. The clinician must consider what the patient is able to do on the day of the assessment, or choose the response describing the patient's ability more than 50% of the time. Most common pairs with observed contradictions during QA are GG 0130E and MU 1830, GG 0130A and MU 1870, GG 0130C plus GG 0170F and MU 1840, GG 0170E or GG 0170D and MU 1850, GG 0170J and MU 1860. Important tips. MU items should focus on ability in the home setting. GG items must reflect usual performance, not best or worst day. If any GG activity uses an assistive device, corresponding MU item is likely not a 0. Caregiver. If caregiver assists in GG section, corresponding MU level will likely be indicating help, supervision needed. If GG is coded 88, 10, 9, or 7, make sure narrative plus MU item explains why. If pain or shortness of breath limits GG item, MU mobility and transfers is likely not to be fully independent. Physical therapy and occupational therapy notes functional ability assessment should match both GG and MU items. Explain exceptions. If scores differ, documentation must clearly explain why, e.g. patient is usually independent but requires supervision due to recent fall. Vital signs and symptom alignment. Next, let's make sure vital signs line up with what's charted in Oasis. Examples O2 sat 84% on room air, but your documentation says no shortness of breath. That's unlikely. Reassess and score MU 1400 appropriately. Patient with heart failure, heart rate 128, respiration rate 28, O2 sat 90%, shortness of breath checked under respiratory assessment, but narrative says patient asymptomatic, clearly inconsistent, needs revision. Hospitalization risk assessment and Oasis documentation. CMS and payers put so much weight on hospitalization risk because it's the single biggest driver of healthcare costs and a top indicator of care quality. If we identify risks early and put preventive interventions in place, we protect the patient's health, the agency's survey outcomes, and our reimbursement under PDGM and VBP. In Oasis and home health documentation, you always want the clinical status, objective findings, comorbidities, vitals, functional limits to line up with the identified risk of hospitalization. If the patient is high risk on paper, the chart should show why. If patient is low risk, the documentation shouldn't show multiple red flags without interventions. Ensure Oasis risk items, MU 1033, matches nursing narrative, vitals, and functional scores. Ensure care plan interventions directly address risks identified. Examples: patient takes 12 meds daily but often forgets doses. MU 2020, management of oral medications, should reflect partial or full assistance needed. MU 1033, mark non-compliance with meds as risk factor. Mark polypharmacy under fall risk. If patient is unsafe with meds, it must align with functional scoring and care plan interventions. Patient has stage 3 pressure ulcer and is on oral antibiotics. MU 1306 to 1342, wounds. Must reflect presence, type, and status of wound. MU 1033, infection and wound risk must be marked. Potential risk for infection assessment should be completed with wounds, medications, high risk for infection identified, all checked. Use hospitalization risk assessment tools. Narrative wound measurements must match those in the wound assessment section. Examples of proper alignment documentation for a high-risk patient: diabetic wound patient with a non-healing foot ulcer, A1C 9.2, has neuropathy and requires wound vac dressing changes. Hospitalization risk should be selected as high due to infection risk. Interventions: skilled wound care, blood sugar monitoring, foot assessments and instruction, infection prevention teaching. Documentation: narrative should explicitly connect poor glycemic control to wound healing and risk of infection and rehospitalization. Other examples of common red flags and misalignments include: 1. Chart says low hospitalization risk, but patient has had multiple documented ER visits in the past 6 months, has severe CHF and COPD with unstable vitals, and 2 recent falls, but high fall risk not addressed. No documented interventions in patient's chart. 2. Chart says high hospitalization risk, but patient documented as clinically stable, has good family support with no documented exacerbations. No care plan elements justify high risk, or high risk identified but no documented monitoring, and no care coordinations or communications with MD. In Part 2, we'll take a deeper dive into diagnosis coding and its impact on PDGM, orders for discipline and treatment, goals, medication profile, and general Oasis QA best practices. Be sure to watch the next video to see how it all ties together. Thanks so much for watching. If you found this video helpful, give it a thumbs up. It really helps others find it too. Don't forget to subscribe so you don't miss out on more tips and resources. Looking for easy-to-use digital tools for managing home health? Check out my Etsy shop. Link is in the description. If you have questions, ideas, or want to share your experience, leave a comment. I'd love to hear from you. And feel free to share this with anyone who might find it useful. See you in the next video.